Hello, and thank you for joining this OncLive peer exchange titled Moving Toward Precision Medicine in Adult Acute Myeloid Leukemia. Use of next-generation sequencing technology has generated a plethora of novel insight into the genetics of AML, providing important information about dysregulated signaling involved in leukemic transformation and leading to new therapeutic targets. After dearth of new therapies available for acute myeloid leukemia over the last few decades, we're transitioning into a new era with several promising strategies in late-stage development. This expert panel discussion will focus on the latest advances in treatment for patients with AML and will provide practical information on how to use the newest therapies. I am Elias Jabbour. I'm an associate professor in the leukemia department at MD Anderson Cancer Center in Houston, Texas. Participating today on our distinguished panel are Dr. Harry Erba, Professor of Internal Medicine and Director of the Hematologic Malignancy Program at University of Alabama at Birmingham, Alabama. Dr. Mark Levis, Program Leader of Hematologic Malignancies and Bone Marrow Transplant at the Sidney Kimmel Comprehensive Cancer Center and a Professor of Oncology at Johns Hopkins University in Baltimore, Maryland. Dr. Richard Sohn, Professor of Medicine at the Harvard Medical School, Associate Physician of Medicine at Brigham and Women's Hospital, and Chief of Staff and Director of the Adult Leukemia Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. And Dr. Martin Tallman, Chief Leukemia Service in the Department of Medicine at the Memorial Sloan Kettering Cancer Center and Professor of Medicine at the Weill Cornell Medical College in New York. Thank you so much for joining us. Let's start. So today we'll have two segments essentially, starting discussing the state of the art in management of AML, and then we move to the second part where we're discussing the clinical trials, the new drug they are promising, and hopefully to get them approved in AML. I want to start with Dr. Tallman. Today somebody coming to our clinic with AML, let's say young adult AML. So what step or what are the diagnostic procedures that can decide on therapy, and what is the standard of care for these patients?
I think among younger patients there has been a significant change, including among older patients, in terms of trying to identify prognostic factors that can predict how a patient will do with intensive chemotherapy or less intensive therapy. For younger patients, most of whom can be treated with intensive chemotherapy. And we try to risk stratify those patients, and we always obtain cytogenetics and molecular genetics, immunophenotyping, I think, as standard therapy. But for patients who are under age 55 to 60, most of whom can tolerate intensive chemotherapy, a standard of care today would be, if a patient is not participating on a clinical trial, would be to receive induction chemotherapy, intensive induction chemotherapy with an anthracycline, either daunorubicin or idarubicin, for 3 days and 7 days of continuous infusion cytarabine. There has been several recent studies that have suggested that among younger patients, in fact patients up to age 65, higher than formerly used doses of daunorubicin may be beneficial. So up to age 65, I think it's become standard of care to administer 90 milligrams of daunorubicin per day for 3 days and continuous infusion cytarabine.
So there was a study last year about lower dose of anthracyclines instead of the 90 to go back to 60 or idarubicin 12. Do you have any thought on that? Or
I think that there is not clear. It's clear that I think everyone should receive at least 60 milligrams. I think 45, which is actually the original approved dose, is probably inadequate. I think there hasn't been adequate proof that 90 is definitely greater than 60, but it certainly is safe and tolerable. So up to age 65, I think there's sufficient data to justify 90 milligram dose.
And how about high dose RSE in induction?
High-dose RSE induction has been studied. There's been no clear benefit, and I think as long as patients get high-dose cytarabine and consolidation, there's no clear role for routine use of high-dose cytarabine during induction.
So you mentioned what is the minimum to be done before starting therapy? Today in our practice, there are a lot of labs. They can get cellular, tons of gene testing. What does, for a physician in a community, what a physician does need to do, the minimum, in order to decide on therapy, whether you go for transplant or chemotherapy or clinical trials?
Well, I think immunophenotyping should be done on all patients. I think cytogenetics should be done. I think molecular genetics should be done. And of the molecular genetics, there are all kinds of panels now that one can send 30 gene panels, 400 gene panels. But I think in terms of what is actionable or targetable are several. And I think all patients, of course, should have the FLT3 mutation, ITD and TKD done. They should have IDH done. I think they should have a CBP alpha done, and I think they should have the C-kit done. I think those are the major ones.
and NPM1.
And NPM1 should be done,
Okay.
of course.
No, that's great. So I want to go to Richard. So most of our patients, they are 60 years and older. AML it does increase with age. Unfortunately for these patients, they have comorbidities. How do you define unfit patients, and what is elderly people? You can have somebody who's 65 well fit. You can have somebody who's 55 already performance of 4. So how do you define your practice unfit, and what you suggest for them?
Well, that's a really great question, and one that's been asked for the last umpteen years about AML. The median age of AML is 68 or 70, so you're absolutely right that most of our patients are older. And we try to get away from the word elderly. It's a bit pejorative, so we like to use older, especially as some of the panelists are getting to that age group right now. Anyway, the definition of unfit is really a huge bugaboo, and I tried to get away from that. I tried to think about, as Marty was saying, 2 major factors: fitness, biologically, comorbidities of the host or the patient, and then the appropriateness biologically of response to chemotherapy, or the likelihood of response to chemotherapy based on disease-related factors. So when I do see a patient who's over age 65, I say, A, are they fit? Could they withstand the chemotherapy within a reasonable likelihood? Are they going to have a huge mortality rate? And to make a long story short, the performance status, if they're 3 or worse, they're going to do miserably with chemotherapy. And as far as the disease biology, I'm sure we'll talk a lot more about that. But P53 mutations, complex cytogenetics, those people aren't going to do well with 3 and 7. And so I'd be more apt to treat even perhaps a sort of fit patient with a less intensive therapy, although there's a lot of discussion about really whether that's a good idea or not.
So what is less intensive chemotherapy today?
Today, less intensive chemotherapy in the US, even though it's not approved, is a hypomethylating agent. Azacitidine or decitabine. In other countries, low-dose Ara-C is still used a lot, especially if that country does not have an approval for one of the hypomethylating agents.
So before we move to the new therapies, because obviously, as you mentioned, it's needed for these patients, we give therapy for these patients. How do you assess efficacy? It's CR, complete remission, or improvement of the count, or living longer? And here I want to ask you first for the elderly patient, and then I want to go back to Dr. Tallman about those who are young, well fit.
Well, for the older patient, if they're getting intensive therapy, and many will do so, we still use standard histologic complete remission criteria. We probably should think about moving to a more nuanced definition of remission, that is by using either molecular or immunophenotypic studies to assess for minimal residual disease. For an older adult who I'm giving non-intensive chemotherapy, I tend to view, for good or ill, my treatment strategy being the same as it is for mild dysplasia. Okay. Keep giving the drugs until progression or severe toxicity.